Today, the topic of our article is a rare case of large intraventricular meningioma. It's a case report. Authors are Dr. Tushar V. Soni sir, Dr. Mayuresh Rampurkar, and myself, Dr. Vinay. Though meningiomas comprise 15% of all the intracranial tumors, intraventricular meningiomas are rare intracranial tumors comprising of only 0.5 to 3% of all meningiomas. Most intraventricular meningiomas arise in the lateral ventricle, especially from the trigone. They are observed more frequently at a younger age group than any other age groups. They are classically large and have a silent evolution. However, CT and MRI over the last few years have helped neurosurgeons to make the precise diagnosis and guide their surgical approaches. Meticulous and rational planning enable complete removal of these usual benign tumors, offering permanent cure and long-term survival. Intraventricular meningiomas usually present over due to the mass effect, either by the direct compression of the adjacent or from the obstruction of the normal CSF drainage, resultant in hydrocephalus. In general, these meningiomas are more commonly of the fibrous meningiomas and have a benign clinical course. Here we present a 41-year-old healthy male patient came to our OPD with a history of headache, during of vision, imbalance while walking, and abnormal movements of whole body. Usually generalized tonic-clonic convulsions since 5 months. He was conscious owing to time, place, and person. His vitals were essentially normal. His finger counting was 2 feet in both eyes with pupillary light directions normal. Extraocular movements were normal. Other cranial nerves were intact. Power was decreased onto the left side with left upper limb 3 plus with poor hand grip and left lower limb 4 minus. Power on the right hand side was normal. Hypertonia was noted on the left upper and lower limb. Reflexes were present on left side. Sensory examination was normal. No other abnormality was detected. Fundus suggestive of papillary edema. MRI brain suggestive of 7 by 6 mm centimeter lobulated well-defined altered signal intensity lesion seen possibly arising from right occipital horn and trigone of the right lateral ventricle with compressive effect in form of 13 blade 9 shift to the left and right ankle herniation. Dilatation of left lateral ventricle suggestive of developing obstructive hydrocephalus. Onto the left side is the preoperative CT scan and onto the right side is the preoperative MRI showing a space occupying lesion on the right side of the brain. After thorough preoperative necessary workup and anesthetic fitness, right temporoparietal craniotomy and excision of right lateral ventricle space occupying lesion surgery was planned. Patient was operated under general anesthesia in supine position with head turned towards the left side with pillow onto the shoulder and head fixed over the Sugita head fixator. A right parieto-temporal incision was taken and craniotomy was done. Tumor was excised with the help of a bipolar cautery and tumor holding forceps under microscopic view. Hemostasis was achieved, dura was kept open and bone flap was kept back. Closure was done in layers and procedure was uneventful. Post-operative patient symptomatically improved with decreased headache, improved vision, bilaterally 6 by 18 from preoperative finger counting 2 feet, and power improved on the left side became 5 by 5 and left upper and lower. Patient was discharged after suture removal. Histopath suggested of meningioma grade 1. Onto the left side is the resected specimen and onto the right side is the histopathological slide provided by a pathologist. Onto the left side is a postoperative scan showing the complete tumor removal on the right side of the brain, and onto the right side is the postoperative photograph of the patient with no focal neurological deficit. Meningiomas are the most common benign intracranial masses comprising of 50% of all the intracranial tumors. Intraventricular are rare as such as 0.5 to 1% and more commonly seen in 3rd to 6th decade of life with more of female predilection. More commonly seen in the trigone of the lateral ventricle as choroid plexuses are bulkier in the lateral ventricles. Slightly more left frequent on the left side. Characteristically, they do not have a dual attachment like other usual meningiomas. Diagnosis is often delayed because of the slow development of tumor in extensible space. CT scans and MRI prove very helpful in diagnosis of meningiomas. Meningiomas are hypotense on T1, ISO or hypertense on T2. Contrast enhancement is important for both CT and MRI. And histopath usually suggests of fibrous, fibroblastic or pseudomatous and exceptionally malignant. Surgical excision remains a logical solution and despite difficulties, large size and tumor removal must be the aim. Several approaches are advised. The temporoparietal approach by Cushing, posterior midline temporal gyrus approach by De La Torre, and posterior parietal occipital approach described by Kramer. In literature, it varies from 0 to 42%, however, mortality is around 25%. The endoscopic resection seems to be less invasive and safer and smaller for IVMs, but not for practical purpose as for large and highly vascular ones. Here we conclude that intraventricular meningiomas are rare. It has benign course similar to other meningiomas, but can cause hydrocephalus and focal neurological deficits like vision loss and weakness. In contrary to historical beliefs, prompt and planned surgical management gives a good outcome. Thank you so much.